Thank you for joining us today in the next webinar in our oxygen series, Care of Pediatric and Adult Patients. Today we are talking about device management. We have a great panel today. It includes Dr. Demelash, Chair, Biomedical Imaging Stream, Addis Ababa University, Dr. Anna Maria Crawford, Anesthesiology and Critical Care Medicine, Stanford University, Jim Stunkel, Vice President and Director of Program Operations for Assist International, Debbie Lester, Global Health and International Development Specialist, Benjin Joshua, Senior Program Manager, Medical Programs at Assist International, and Erin Sharkey, Program Coordinator for Assist International. I'm now going to pass this over to my colleague, Benjin Joshua, to start us off.
Thank you so much, Monica. Please allow me a few minutes while I pull up the presentation. I hope you can all see my screen. Before we begin today, I just want to clarify what we're going to be presenting on. We recognize that as a part of oxygen therapy, there are multiple devices, medical technology that is involved. We've got ventilators and CPAP machines, oxygen concentrators, we've got oxygen cylinders and pulse oximeters and other devices that are critical to making sure that a patient receives oxygen. Based on our experiences in low and middle income countries, today's presentation will focus on two of the most commonly found oxygen delivery mechanisms in low and middle income countries. So we'll start off with oxygen concentrators and then we'll transition to oxygen cylinders. And we'd like to talk about how we have seen people manage these devices to best support patient care. And based on some of the trainings we've done, we'd like to suggest a few tips, a few tricks that you can keep in mind to make sure that oxygen is safely delivered. If you're interested in other devices such as ventilators, pulse oximeters, we've already covered that in prior sessions, and I'm sure we can get you access to those sessions if you would like to, like a refresher. With that being said, I'd love to introduce my friend, Dr. Masreshaw from Ethiopia. He's the chair of the Biomedical Engineering Department, as Monica mentioned. And Maz, over to you.
Okay, thank you very much, Benjin, and hello, everyone. So my name is Master, and I'm from Ethiopia, as Benjin introduced, from Addis University Center of Biomedical Engineering, and I will give you an overview of oxygen concentrator and including the working principle. And then, I will pass it to Benjin back to walk you through the most important alarms that you need to be aware of as a clinical, as a clinician or as a user. Okay, so just to start, what a concentrator is. A concentrator is, in short, an oxygen therapy, medical device that's used to provide or deliver oxygen to a patient or to someone who needs oxygen. I mean, someone may need oxygen or may have a condition that results in, for example, low level of oxygen in the blood, and in that case, of course, someone needs medical grade purified oxygen, something above 90%, 93, 94, 95. Yeah. So an oxygen concentrator, in short, provides purified oxygen to someone who needs oxygen, in short. And as the name indicates, oxygen concentrator, it concentrates ambient oxygen. I mean, it concentrates oxygen from ambient air, which means that normally ambient air has around 78% nitrogen and 21% oxygen, and the rest 1% other gases. So what oxygen concentrator does, it takes in ambient air and then it separates oxygen from mainly nitrogen. Okay, and then it provides a medical grade oxygen somewhere, up to 93%, as I said. So the way the technology, there are of course a couple of technologies to do that. It does in oxygen concentrator to separate a mixed gas is, a pressure swing adsorption that I will come later on for more detailed discussion on that. But in short, oxygen concentrator is an electrically powered device, and it's very portable one. You can move it from one room to the other room. You can use it at home also. So it's like most common and preferred, let's say, oxygen delivery system in low and middle income countries in general. Okay, so I'll move to the working principle. So how does an oxygen concentrator works? So in general, it takes an ambient air, as I said, which is around 78, 8% nitrogen, but around 78% nitrogen and 21% oxygen. So it takes in through a filter. So it has to filter dust and other particles. Okay, and then that is done by a negative pressure to suck air in. And because now when you compress air, the temperature increases, so we have a heat exchanger to cool it down. So the compressor takes atmospheric pressure in, which is around, let's say, 14.7 psi, and then it compresses it up to 50 psi, and then it leads to the two seabeds. You see the two cylinders you see there, red on the top. So then this is a sieve bed. In this sieve bed we have a zeolite material. So when a compressed air, high pressure, mixed air passes through this zeolite material, the zeolite material adheres or absorbs nitrogen and allows oxygen to pass through. Okay, so on the bottom side you have a purified oxygen coming out. Then in the next step, the adsorbed oxygen, when we take the pressure off from the top, when we depressurize the seabed, the adsorbed nitrogen will be exhausted out. So at the same time, in this case, the second seabed will be pressurized so that we have oxygen produced. So you see that this is a cyclical process where when one seabed is pressurized, the other is depressurized, so that we have a continuous supply of oxygen coming out of the two seabeds. So the output oxygen, produced by the two seabeds is connected to the oxygen tank, the red, cylinder you see. So it's like filling an oxygen cylinder from a commercial, let's say, oxygen plant, if you like. And then this is connected to an oxygen regulator, like how we attach, regulator to the cylinder. And then we have, a flowmeter to limit, the flow of, oxygen gas, like 5 liters per minute, 3 liters per minute, depending on the prescription. And then that's connected to the patient via, it could be nasal cannula or a face mask, which I believe are discussed already in the previous slide. So this is how an oxygen concentrator works. And of course, all these things are, managed and controlled by, of course, a processor. So oxygen concentrator comes with central processing unit as well. So this is how an oxygen concentrator works. So you see now in this, so the same picture. So in this process, there are so many things that can go wrong. For example, the external filter could be blocked and no air may come in. So in that case, you expect low pressure to happen, and then of course that's malfunction. Then you'll hear some alarms. Or for example, the flow may be blocked, or there could be high or low pressure, which is beyond the range. And those things, are associated with alarms that my colleague will go through later on. So as a clinician, as a user, I think it's very important to be able to know the specification of the oxygen concentrator that you need. It's very important, because unless you specify the right concentrator, then you get the wrong concentrator finally. So the most important ones, of course, as I said, it is very portable mobile device. So it should have 4 wheels with brakes that you can brake to stop it while you are using it. And when it comes to flow rate, it should be able to supply oxygen continuously, and the purity level should be 93% plus or minus 3, which means like from somewhere 90% to 95-96%. Okay, and of course the output pressure more or less close to the atmospheric pressure, which is from 6 to 10 psi. And of course, the noise level, the muffler, the exhaust air goes through the muffler, and that should not produce too much sound. So it should be below 55 decibel. Okay. And also we have to make sure that the oxygen concentrator comes with 4-step filtering, starting from the coarse filter, which is on the outside, up to the bacteria filter. That's also very important to mention, and this is according to WHO, by the way. And also it should come with audio and visual alarms for, as I said, low oxygen concentration, because we are talking about zeolite material that can be depleted after working some 15 or 20,000 hours, which means after that time the oxygen concentration goes down. So we should be able to get some feedback, to know about it. So there should be some alarm for that, and also, as I said, high or low pressure alarm, and also power failure alarm, and so on. My friend Benjin and my colleague will go through all these alarms that you need to know as a clinician. And also very important, especially in a setup like Ethiopia, it's very important to keep in mind the continuous supply of parts and accessories, which is really an immense challenge, because you buy oxygen concentrator, it can run for the first few months, but then when you run out of, when you need some of the accessories or parts, then you need to be sure that you can get continuous supply of those parts and accessories. This is very critical that you need to consider when you specify a concentrator. So with this, I pass it to Benjin, and as I said, he will walk you through the most important alarms. Thank you very much.
Thank you so much, Maz. So as a clinical user, you're probably wondering about some of the information Maz presented as it relates to pressure, the purity of oxygen that the device is putting out, all of the components of the devices, of the device itself. And while we recognize that you are unable to perhaps go at an in-depth level and repair and troubleshoot an oxygen concentrator, we want to touch on a few key first responder type responsibilities that we can share with you, and you can consider applying this in your practice as you deal with oxygen concentrators. We also have several modules that go in depth on the maintenance and repair of oxygen concentrators. And so if you have biomedical engineers or technicians who work at your facility or who work in your district or even in your region, please refer them to our resources. We're happy to share that with them. We have recorded sessions they can participate in and see how to perform in-depth repair and maintenance of oxygen concentrators. With that being said, we want to touch on a few key alarms that you can be aware of. The audible alarms, there are typically three main types of audible alarms when it comes to oxygen concentrators. The first type is a short beep that is followed by a long pause, and you'll hear that continuously. So you'll hear the sound once, the noise once, the beep, and then you'll wait and you'll hear the beep again. And with these types of alarms, you want to be looking at a few key things. you may see that the concentrator is not operating even when you turn on the oxygen concentrator while this alarm is present. You want to look at the power cord. Make sure the power cord is plugged in. And if it is plugged in and the alarm exists and the oxygen concentrator won't turn on, you want to make sure that there's power at the outlet itself. And one way to do that is to check and see if the in-house circuit breakers or fuses are all intact. You may have an engineering team or a maintenance team that can come and verify that. Another way to do that is by plugging in your device into another outlet and see if the device will turn on. So once you go through checking on the power cord, ensuring that there is power at the outlet, then you come to perhaps an issue with the oxygen concentrator itself. And this is typically something we would see with a power compressor. And the issue here is usually that the device has run too long and has overheated. And so it just needs to cool down a little bit before you start using it again. And then if you have a maintenance team, a technical team that can take apart the oxygen concentrator, there are other things they can look at as to the reason why the oxygen concentrator itself is overheating and causing the compressor to shut down. So power cord, make sure there's power at the outlet. And if the power cord is okay and there is power at the outlet, it could very well just be the overheating of the compressor. So just let it be for a little bit, just leave it alone and come back to it in a few hours after it's had a chance to cool down. The second type of audible alarms that you'll encounter in the use of oxygen concentrators is a continuous beep. It's perhaps one of the most annoying sounds that you'll come across in this lifetime. And it'll just stay on for a while and the beep just stays on. And when you try to again turn on the unit, it will not turn on. So what are some of the main causes of this? It can be to the unit overheating due to blocked air intake. It can be to insufficient power again at the outlet, and there could be other internal repairs that are required. In case it is of overheating due to blocked air intake, one thing you can do is just remove and clean the cabinet filters. So if I could go back to a few slides, the cabinet filters would be right at where the air is coming into the unit itself. It's actually quite easy to remove the housing and just take out the filter and clean it up and wash it. It's typically a washable filter. It's a very quick, easy way to make sure that there is no blockage in the oxygen concentrator. Another thing that you can consider is moving the oxygen concentrator away from the walls and draperies or furniture, at least 3 inches away. If you end up putting the oxygen concentrators really snug against a wall, it can block the free flow of air into the unit, and the unit has to work extra hard to pull more air in, and that can cause overheating. And another thing that you want to consider is the use of extension cords. We have seen the widespread use of inappropriate extension cords in medical facilities in low and middle income countries. In most Western contexts, there are medical grade extension power cords that are utilized that can handle the kind of energy draw that is needed to sustain multiple medical devices. But we've seen many times just the use of cheap extension cords in hospitals, and this can be very dangerous. We've seen a lot of burning of medical devices, their power cords catch on fire, including devices like infant warmers and incubators that are especially critical in terms of keeping newborns alive. And so we would recommend not using extension cords, as this can cause a lot of power related issues, and you'll probably hear a long, annoying beep sounds from your oxygen concentrator if this is not taken care of. These are all very simple first responder things that you can take care of and make sure that your healthcare facility is utilizing oxygen concentrators in a safe manner. The last kind of audible alarm that you'll hear quite in the use of oxygen concentrators is a rapid beep. So this is, as opposed to the first alarm, which has a beep and then a long pause, this one will just go beep, 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 beep. It's just multiple, it'll just stay on for a while and you'll hear the rapid beeps. Now this can be due to two primary reasons. The first one being that there could be a blocked tubing, and this includes the cannula or the humidifier as well. So we're not looking at just inside the oxygen concentrator, we're looking at the flow of oxygen from the device to the patient, and you want to look at that circuit very carefully to make sure that there are no kinks or blockage. The second reason for this type of an alarm would be the flow meter being set at 0.5 liters per minute or less. And so the solutions are quite simple. Just make sure there are no kinks or blockages. Make sure that you clean and replace any of those pieces, the humidifiers, the cannulas as needed. And my colleague Jim Stunkel will go through this with some pictures in depth in a little bit. And once you have resolved the issue, whether it's a kinked tubing or a blocked tubing, you know, a humidifier that needed to be cleaned out, you want to turn off the power for about 60 seconds and then power it back on. And typically you can get rid of that type of an audible alarm. When we were trying to put all of this content together for you, one of our team members brought up an experience where they found that the hospital had cut the audible alarm out of the oxygen concentrator because it was just making an annoying sound. Please do not do that. Please make sure that your technicians and engineers aren't cutting alarms out of oxygen concentrators. These devices are designed to warn you and to have you pay attention to some very key things that will be required to make sure the device works for a very long time. So if there's an alarm, pay very close attention and try to get to the bottom of it. There are also some visual alarms besides audible alarms. You'll see there may be a yellow or red light that is illuminated in some cases. And so some of the causes here can be low oxygen purity. It could be kinked or blocked tubing. Again, flow meter being set below at a flow that is below 0.5 liters per minute, or it can also be due to overheating because of blocked air intake. So the solutions here are, again, quite simple. Just like with the audible alarms, you want to make sure that the filter is clean and it's replaced, or if it's make sure it's clean and washed. Make sure there are no kinks or blockages in your circuit, and make sure the humidifiers are clean and there's no blockage in there. And if it is due to kinks or blockages, once you resolve that issue, you can turn the device off for about 60 seconds and turn it back on, and you'll typically see that the light won't be illuminated. Make sure if it's because of the flow meter being set to less than 0.5 liters per minute, you change that to at least 1 liter per minute. And then make sure that your concentrator is at least 3 inches away from the walls, draperies, or furniture to ensure that there is adequate flow of ambient air into the oxygen concentrator when it's turned on. We do want to clarify one quick point with all of these alarms. These are based off of our experiences with the Airsep concentrators. And while a lot of the oxygen concentrators have very similar mechanisms and alarms, we encourage that you advise your technical team at your facilities, your engineering maintenance teams, to thoroughly peruse the service manuals, the technical manuals that come with your brand of oxygen concentrators. If any of you need support with finding technical manuals, please reach out to us. We're happy to support you and see how we can provide those resources to you as well. Oftentimes, these technical manuals will have very detailed specifications on alarms and troubleshooting mechanisms that are specific to that model of the oxygen concentrator. And that would be very critical for you to know, or for your technical teams to know. And I want to go through just the last, just 2 more slides of quick troubleshooting guides these get a little bit more in-depth as we go along. So if you have a technical team, please refer them to our resources where we go through these troubleshooting guides in depth. There is a battery test. So when you turn the device on at first, for devices that have batteries in them, there will be a 5-second audible alarm. If this alarm does not sound, that means that you have to replace the battery. And oftentimes that if the batteries aren't replaced, it also means that other audible alarms won't come through the system. So when you turn it on, if there's not a 5-second audible alarm, please have your technical team look at replacing the battery on your oxygen concentrator. There's a power disconnect alarm. If the power to the unit is turned off while the unit is in an on position, a continuous alarm will sound. This is a good way to test and see if the alarm is working on your system. So while it's turned on, you just unplug the power cord, there should be a continuous audible alarm. And if you don't hear that, change the battery. There's a high pressure alarm. This is another way to test the alarm system. If the system pressure rises above the normal operating conditions, a 1-second audible alarm followed by a 1-second pause will sound. So to test this, you disconnect one wire on both of the waste valves and turn the unit on. Again, this is a little too technical, and maybe a technical team or your engineering team might be able to do this. And when you turn on, disconnect one of the wires on both of the waste valves and turn the unit on, the alarm must be activated before the pressure relief valve opens. So you'll be able to test and see if this high pressure alarm system is working on your device. There's the low pressure alarm as well. It is activated if the system pressure falls below normal operating conditions. So this is again a 1-second audible alarm followed by a 1-second pause. And the low pressure light on the main circuit board will be turned on. This is specific to the Airsep. They'll have the model that we were looking at had a low pressure light on the main circuit board, and you'll be able to see that the low pressure alarm system is working. Oxygen concentration alarm. Maz had mentioned this. If the concentration falls below, in this case, 85%, the WHO specifications allow for oxygen concentrators to have a minimum of 82% oxygen purity. But the Airsep device that we were looking at, they've set the bar at 85%. So if the concentration falls below 85%, the alarm is 2 half-second beeps followed by a pause. There'll be a yellow LED on the front of the unit that will be illuminated. Not many devices have this type of an oxygen concentration alarm. There's a high temperature alarm, and the thermal switch alarm will activate in the event of an elevated internal cabinet pressure or temperature. And this will turn the compressor off and sound the alarm. It'll be similar to the low pressure alarm. With high temperature, if you recall, I had mentioned that you move the device away from the walls, make sure that the cabinet filter is clean. These are some ways that you can make sure that your device does not overheat. For your technical teams, I just wanted to put this resource out there. We've got extensive maintenance checklists that are available that we use for training when we train technicians and biomedical engineers. And so we've highlighted just 3 quick things that I'm happy to share with you. The oxygen concentration is very important to measure for your device. We've seen numerous cases where the oxygen concentrators are working at less than 60–50% oxygen purity, but the assumption is that it's putting out oxygen that is the purity of 93% or higher. And the way you test for that is by using an oxygen analyzer. And so we train our biomeds to set the flow to 1 to 3 liters per minute and try to see if the oxygen concentration can be measured at anywhere between 92 to 96% purity. And if that is not achieved, if it's below 92%, we consider that as failing. And then the biomeds will go through a series of steps to make sure that the device gets calibrated. We repeat the test at 4 liters per minute, and this time we check, make sure that the oxygen purity is between 89 to 96%. So if at 4 liters per minute, it produces less than 89% purity, then again, the biomeds have a series of steps to follow. And the last test with the oxygen concentration is at 5 liters per minute. The flow is set at 5 liters per minute, and we try to make sure that our biomeds, that the device can operate, can put out oxygen that is 87 to 96% purity. You will probably notice as you increase the flow, from 1 to 3 to 4 to 5 liters per minute, you'll see that the tolerance for oxygen purity goes down. As the flow increases, the purity of oxygen decreases. This is very critical to remember because oftentimes we've seen clinicians account for, think that they can increase the purity of oxygen by increasing the flow. That is not necessarily the case. The devices are designed to put out a certain flow, but because of the way pressure swing absorption works, as you increase the flow of the flow of air through the device, it'll reduce the purity of oxygen that's coming out on the other end. So you want to, your biomeds are able to test with oxygen analyzers to make sure the device is working within specifications, but this is just something that you can just keep in mind as you deliver, deal with oxygen therapy. Here are some of the key test equipment that your technical teams will need. They will need a digital pressure meter, as well as an oxygen analyzer and multimeters. If they have these key testing devices and a standard toolkit, they will be able to repair almost anything on an oxygen concentrator. I want to end my portion of the presentation with just a quick talk about the filters. The oxygen concentrator has multiple filters on them. One of the filters, which is the air intake filter, this right here, is the filter that I had pointed out in the picture of the diagram of the oxygen concentrator. This filter can be cleaned and must be cleaned. It can be washed and must be washed. There, and this is very critical to make sure that there's good flow of air into the unit. Oftentimes, if the unit is overheating, there's blockage. This filter you'll see will be clogged with dirt, with dust. And so it is very important to keep an eye on this almost on a daily basis. There are other filters in there, for example, the product filter that is inside the device itself. This needs to be replaced every 10,000 hours. Again, you need to reference the service manuals to see exactly what the manufacturer would recommend. Our recommendation is that you switch these out every 10,000 hours. This is a little bit of an involved process. Your biomed teams should be able to do it, and we're happy to show them how to do it if they don't have that type of training. Please also track the hour counter on your oxygen concentrators. Most oxygen concentrators will have hours listed on there. As Maz mentioned, the zeolite tanks, the sieve beds need to be replaced every 20 to 50,000 hours roughly. And so depending on what your manufacturer recommends, you want to track the hours. And when you hit the limit, you want to make sure you flag this for your hospital administration or your technical teams. Listen, this oxygen concentrator has hit 30,000 hours, and I think we need to replace the zeolite tanks, or the zeolite, the sieve tanks. So please pay attention to this, and please pay attention to the air intake filter. And then the rest, you leave it up to your technical teams. And if they need help, please send them our way. We're happy to have them reference our training sessions. With that being said, I would like to transition this presentation over to my colleague, Jim Stunkel, who will walk through some other accessories, consumables, some components related to oxygen cylinders. Jim, over to you.
Thank you very much, Benjin. Monica, am I on here? Is this working well?
You are on here. I'm just wondering, there were some questions that came in through the chat box about Benjin's presentation. If we want to just tackle a few of those. I know Anna has been chatting with these individuals throughout, but perhaps we can just talk a little bit about those and then move into your presentation, Jim.
I think that sounds good. Let's peruse those questions. Monica, would you like to administer that question and answer? Benjin?
Yes. Anna, do you want to do those that you haven't already addressed, or do you want me to?
So there's some really great questions that came in through the chat box. One is for an oxygen concentrator. Why is it not possible to have 100% FiO2? And so I defer to Benjin on this, but my answer is that just the technology that oxygen concentrators use, that they actually use room air and remove nitrogen. So the highest FiO2, or fraction of inspired oxygen, is really probably mid to low 90s. And then, as Benjin astutely pointed out, the higher the flow, you actually may get a lower concentration. Did you want to expand on that any further, Benjin? You did a great job explaining that. Thank you.
No problem, Anna. Yeah, your answer is perfect. I couldn't have said it more eloquently.
So Anna, I would add something. This is Jim. Sometimes we have an idea that it would be really great to have 100% pure oxygen, but it's really not necessary for the clinical purpose, because as oxygen is administered through the nasal cannula, ambient air from the atmosphere is also being inspired to the patient's lungs, and many of the masks also have ventilations in the masks, so you're still getting ambient air. It's really not essential for any particular clinical purpose to have 100% oxygen. By the time the patient inspires the air, it's not going to be 100% anyway. So the standard of having up as high as 96% will meet any clinical need that you have, and the patient will not be deficient for having only 90 to 96% oxygen. It's quite adequate for all medical purposes.
So Jim, I would probably just argue a small point there, in that I wouldn't use the word all or any, in that it depends on the oxygen delivery device. So you're 100% correct that if you're using a nasal prong or cannula, you're using an oxygen mask, et cetera, that the difference between 96% and 100% is probably not clinically relevant. However, when you get to more invasive devices, such as CPAP masks,
intubation,
that difference in FiO2 could have a clinical difference. So when we're talking about non-invasive forms of oxygen delivery, such as nasal cannulas, oxygen masks, et cetera, then it's absolutely correct that the difference in FiO2 may be less relevant, simply because the patient is also entraining a certain amount of room air, depending on the device you're using to deliver the oxygen.
Really good point, Anna, and I appreciate you making that point, especially for the CPAP and the intubation. I think also, though, while no ambient air is trained in those processes, it's also, can you comment, is it essential to have a higher than 96% oxygen for intubation or for CPAP? Is that ever provided?
Yes, so we often will provide 100% FiO2. I will say that those patients are usually in extremis. So these are very, very critically ill patients, usually in an intensive care unit, usually intubated or on a very tight fitting non-invasive form of delivery, such as CPAP or BiPAP.
Thank you very much. I think we've covered the breadth of that question, so I appreciate it, because a lot of times people are like asking, well, I think we need 100%. I'm saying, well, in most cases, so I'll take away the word all. Thank you for calling that out. In most cases, your 96% will be quite adequate. Thank you, Anna. Any other questions in there, Anna, that you've seen, or Benjin, that you've seen?
I think a good question that I have myself is if you have more than one patient that needs oxygen, but you only have one concentrator, how do you manage that situation? I have seen some things being shared where you can actually have flow meter splits on oxygen concentrators. I'm not quite sure of the safety, so I would defer to our engineers about that. If you could maybe comment if there's a way to run an oxygen concentrator for more than one patient using a flow meter split or otherwise.
Benjin, I think that's a good one for you.
Yes, Mads, feel free to jump in as well. Flow meter splits are perfectly safe for using in a clinical environment. This is something even the WHO recommends as a part of an accessory package to oxygen concentrators. So you can have one oxygen concentrator that operates at say 10 liters per minute, putting out oxygen, and then you can split that flow between multiple patients. There is, from an engineering standpoint, there's not too much of a risk there. The only concern would be, again, how long you run this device and making sure that the purity of oxygen being put out during that time frame is fairly consistent. That would be the biggest gap in most low and middle income countries that we've seen. So you take the risk of providing 60% oxygen that you think is 92% oxygen, and you take the risk of that towards one patient, and now you split that out across 5 different patients. And so that would be the only thing that I would say that just needs to be managed. Before you start splitting oxygen, make sure the technical teams are able to calibrate and let you know with certainty using an oxygen analyzer that the device itself is putting out the kind of pure oxygen you think it is. Maz, would you like to add to that?
Yeah, I think you said it all. I mean, yes, it's safe to be used, but it's important to consider that as we use a single concentrator for multiple patients, then the purity level will go down because the liter per minute, the production is increasing. So then we have to expect that the concentration of oxygen will drop, below 90% for sure. So that's important to keep in mind. Otherwise, that's something possible.
We had a call on Monday that includes a lot of large global health stakeholders, including the WHO and others. And there was a resource shared with us about how to actually design the flow meter splits for an oxygen concentrator. So if you don't mind, Benjin, I'll send you that resource and have you review it. And if it's relevant and safe, we will post it to the Learning Resource Center, which we'll share with you at the end of the conference. So we'll have that resource available to you if it's relevant and if Benjin and Maz feel that it's a safe resource to use. But it seems like it went through in very good detail the methods you would use using old concentrators or broken concentrators or other supplies of flow meters and how you would arrange them as a splitter. So I'll send that to you after the webinar and see if we can post that resource.
Can I just jump in? I'm seeing some other great questions come in, but I do want to make sure we have time to finish off. So Jim, maybe let's jump to your presentation and then come back to Q&A. That's okay?
Yeah, we can do that. We can
Great.
do that. So let me jump in first of all and say thank you everyone for joining. I see some of these great questions. I'm looking forward to getting to those as well. As we proceed into the next segment of this session of device management, I'd like to say that in my personal experience, having worked with oxygen devices in countries from around the world, West Africa to East Africa, Latin America, Central Asia, Southeast Asia, we do see a lot of different examples. So I'm going to show some different examples of device management. What you see may not be exactly what you have in your own setting. That's okay. The principles I believe that we'll be sharing today are generally universal, and so you can consider how these principles would be applied in your setting. Additional comment that I'd like to make is that I recognize that I have a lot of leaders that are attending this training, and sometimes the specific lessons that I'm sharing here are most useful to the end user, and maybe the end user may not actually be attending this training. So for those leaders among you, I hope that you can share these concepts with the end users. And by that, I mean the bedside attendants, the nurses, the aides, and those technicians that set up regulators and cylinders and set the flow meters and make sure that the patients are getting the oxygen that they need. Some of you may be the ones that write the prescription and give the order, and it's other people that do that level of work. But I hope that these principles can be shared forward with those end users that actually do that work. And of course, what we want to make sure is that we get the right drug to the right patient at the right amount. And so in this case, we're talking about oxygen, and we'll transition from the administration through concentrators now to seeing how we administer oxygen through cylinders. So let me share my screen. I think this is coming up, and Monica, I'd like you to monitor me and make sure that I've got the right thing up. Can we see this now?
We can.
The device management of the regulator and flow meter assembly.
Yeah.
What we see here, of course, is the entire assembly as attached to the valve of an oxygen cylinder. And in this session, what we want to do is understand and manage the proper use of the regulators, the regulator gauges, the flow meters, and the humidifiers. And if I look back at this snapshot, it does not have the humidifier here, but in this next slide, you'll see, as shown connected to the oxygen cylinder, the multiple parts of the device. The regulator, flow meter, and humidifier for oxygen therapy. This assembly is what connects to the mask, the prongs, and other devices. So let's specifically identify each part. Sometimes we refer to the whole thing as the regulator or as the flow meter. And the flow meter and the regulator are actually different pieces. Here you see attached to the cylinder, the regulator is actually the one that's piped into the cylinder. The regulator gauge is above the regulator, and then the flow meter is to the side. Below the flow meter is where the humidifier would be installed, and we'll get to that in a moment. So these assemblies attached to the cylinder. So let's start with the cylinder a little bit and see what's going on there. With the cylinder, we see that oxygen cylinders are filled at an oxygen plant, and when they're full, they have 2,200 PSI, that's pounds per square inch, of pressure in the cylinder. And that's important to note that that is considered full. Now, cylinders are different sizes, and we're going to talk about that, but any cylinder, no matter the size, is full at 2,200 PSI. When you connect the regulator to the cylinder, the regulator gauge shows the pressure that's in the cylinder. And here you see the regulator gauge is indicating 2,200 pounds per square inch. I need to make a slight modification in my slide. Here we go. I'm going to want to use this little device, I think. Point out some things. All right. So oxygen is a compressed gas, but the capacity of the cylinder itself is described as a volume of liquid liters, as if the cylinder didn't have gas in it, as if you had filled it with water, for example. You would then be able to identify the volume of the internal chamber of the cylinder. So we see here cylinders of different sizes, and then on the right side of this slide, you see stamped on the cylinders is different numbers that indicate the examples of 50 liters for the larger volume, or 46 liters, and every cylinder will have this stamped. Now, the volume may also be expressed in cubic meters or in liters of gas. So sometimes when we talk about the volume of a cylinder, we need to really be sure what it is the expression that we're using to identify it. But whether the cylinder is 46 liters or whether the cylinder is 50 liters by volume of liquid, in any case, it's always full at 2,200 PSI. The volume will be less in terms of quantity of compressed gas, but the pressure will be the same. Okay. So, so let's take a look at these different volume and capacities of cylinders. Any cylinder considered full at 2,200 PSI. The volume is based on the liquid liter size. And so now we can see some numerics here that compare and help to clarify the different expressions of volume. We see the smaller cylinder is 38 liquid liters. At that point, at 2,200 PSI, you would have 5,700 gaseous liters, which could also be expressed in cubic meters of gas at 5.7. And so you see the same is also true for the medium cylinder. 42 liquid liters is 6,300 gas liters, 6.3 cubic meters, and so on to 48 liquid liters is 7,200. So you can see everyone is full at 2,200 PSI, but the volume of gas that's inside is different. And this is important because as clinicians and as attendants to the patient, by the time we're done with this segment, we want to be thinking in terms of, if I put this cylinder to a patient to share the oxygen from the cylinder, how long is the cylinder going to last? Or how many patients can I serve? So the regulator, the important function of the regulator is to make sure that the patient has the proper flow, but 2,200 PSI of pressure from the cylinder is much too much to be managed delivering to the patient. So the purpose of the regulator is to reduce that pressure to a reasonable working pressure. And so you can see on these green arrows, the indication is, and here in this one arrow, it says 2,250. That actually is the maximum that you will see sometimes coming from cylinders. Generally, we talk about 2,200, but it could be 2,250, 2,200. But in either case, the regulators are preset. They're preset so that the pressure that comes out and goes to the flow meter is at 50 PSI. You see the gauge is still maintaining the indication of the pressure in the cylinder. It does not indicate the pressure going to the flow meter. I want to talk about managing gauges for the regulators just for a moment, because they're different. And here we compare the differences in similarities. The similarity is that all show the pressure in PSI. They all will around the world. But these different gauges also have a different nomenclature for different indicators. But the most common is that they're all will show 2,000 PSI, and you can see that on each of the gauges. But some pressure gauges show also in kilograms. So in this indication, it shows the gauge tells you the lbf/inch squared, that's pounds of force per inch squared, also known as PSI, or kilograms per cubic, per square centimeter is the other nomenclature there. So you see two different numbers on the gauges. You see the 500, the 1,000, the 1,500, or you see the 50 and the 150. One is the kilograms and one is the pounds. In this one, we see the pounds per square inch again, but we also see here they use, this is a little bit unusual, kPa, which is kilopascals. Without getting into it too much, it is 1,000 times the kilos. And here we see one that's more common. This is my favorite gauge because it's color-coded. Here we also again see the lbf, that's the pounds of force per square inch, and the kilograms per square centimeter. In every case, you're going to want to be aware of this pressure on the gauge so that you can manage the amount of oxygen that's being provided to the patient and the rate of flow. You'll watch the gauge being reduced over time as the patient is receiving oxygen. Here's why I like the color code of the gauge. It helps us very much. That part of the gauge, which is in white, are pressures that are not in use. They're above the 2,200. If you see a pressure like that, it's been overfilled. Most filling stations will not allow the pressure to be filled beyond 2,200 or 2,250. It just will not be allowed to be pressurized in the cylinder to that much. So as long as we see the needle of the gauge in the green section, we have good pressure and we can continue the use. But when we see the needle dip below into the yellow section, we want to use caution because that's a low pressure and we need to be considering to prepare stopping the use. By the time we get to red, we want to stop the use and replace the cylinder. So we have many different cylinders. We've discussed that before. We've seen them, different sizes of volumes. We want to manage them, but not only are they different in size and volume, but they're also different in the type of valves that they have. This is important for the end user because the end user is going to need to be sure that they have the right device to connect to the cylinder. And we see that the devices are different. Here are different regulator flow meters. You see the fitting on the left, different than the fitting on the right. Maybe at your hospital, you are fortunate and you have standardized and all of your regulators are the same and all of your cylinders are the same and they match. That's true for many hospitals, but it's also true for many hospitals that there is a mixed assortment of types of cylinders and types of regulators. This is where, as leaders in the hospitals or as end users, you want to have good communication to make sure that you are prepared to have the tools that you need, the right regulators to fit the right cylinders. You may need both. The connections are different. Here shows the different connection and how these work. The nut that you would turn, the way that it fits to the cylinder is different. You will want to be prepared for that. And although the devices are not all exactly the same, the principles of the device management are the same. Here you see completely different looking arrangements of the regulator and the regulator gauge, but really they're doing the same function for you. Please be prepared to be familiar with both kinds. You may have both kinds in your own hospital. So most importantly, and this is something that I really want to strongly share in this session, is that when handling and managing the installation, handle the regulator gently. This is a relatively delicate piece of equipment, and so we want to treat it with great care to prevent damage and the potential failure of the device in the future. So when installing, carefully align the threads to the valve. Use your fingers to gently insert the fitting. Just gently insert it and use your fingers to tighten it. Use fingers to begin the connection and then gently tighten with a spanner wrench. And I cannot emphasize this enough. Use great care. Do not damage the threads. Do not over tighten. It's important because this is the only point of contact where to tighten the regulator and flow meter. Only here. I see sometimes people try to tighten the flow meter some other ways. Do not attempt to tighten by turning or twisting the gauge. Do not hold the gauge in your hand and turn that to fix the regulator and flow meter to the cylinder. You'll break the gauge. Do not attempt to tighten by twisting the flow meter or the humidifier. You'll break the flow meter or the humidifier. Such mistreatment will damage the device. And once the device is damaged, it's going to cause leakage, wasting oxygen, and even your patient care can be compromised. This is an example of a device that has been mistreated. It wasn't properly installed. Over time, you can see now that clinicians, nurses, aides have done many things to try to save or redeem this piece of equipment because it's leaking where it connects to the cylinder, it's leaking at the gauge, it's leaking at the regulator, it's leaking at the flow meter. Why? Because it wasn't handled properly. Because someone did not use great care when installing it to the cylinder, and all of these functions now are not working, and so we're now using surgical tape to try to prevent leaks. It doesn't really work. And I can tell you that in many cases, we know that reports tell us that in certain hospitals, up to 50% of the oxygen that could be provided to patients is lost due simply to leakage. We want to avoid leakage by avoiding damage, and we want to avoid damage by using gentle care to install the regulators and flow meters properly. This is a poor storage example. That's mistreatment. The regulators and flow meters are just thrown here into a box, breaking, damaging each other. You should never see this. I feel sorry for the hospital where they're trying to use this equipment, but they've not learned to respect the storage. These are medical devices that need to be managed and cared for as if they're valuable and delicate. If you store them properly and care for them properly, they will not break and they will last a long time and prevent difficulties for your oxygen therapy. So once we have an example of the same gauge that we saw a moment ago, now it's all bandaged up. You can't even really use it very well. So the question is, how can you possibly read the gauge? It's upside down. It's bandaged. You can't even see. So here's some questions for you. How much oxygen remains in the cylinder for this device? How much oxygen? I would say we see two gradients there. We see in kilos and we see in pounds per square inch. Which pressure is which? I'll give you a moment to think about that. We'll go to the next slide. Here's your answers. How much oxygen remains in the cylinder for this device? Well, we know that full is 2,200 PSI. The gauge shows about 1,300 PSI. You have to read it upside down because that's the way it is on the cylinder. Very difficult for the clinician. What that means is therefore that there's a bit more than 50% of the pressure remaining in the cylinder. So what pressure is this? The first one, that's 1,500, that's 1,500 PSI. And the one below, what pressure is that? That's 100 kilograms of force per square centimeter. So managing the flow meter is most critical, the final step in managing this device to ensure the proper flow of oxygen to the patient. How do we manage the flow meter? Well, first of all, number one, we open the flow meter, and you can see in this case, the arrow points to the green knob, says open or shut. That's how we will open the flow meter. The pressure is coming in from the cylinder through the regulator, reducing from 2,000 PSI to 50 PSI. We're going to open the flow meter. And then number two, we're going to adjust the flow. The ball will rise or lower as the knob is adjusted to indicate the flow rate. So we'll not only open the flow, but we'll control the flow with that green knob. The gauge is not indicating the flow. The gauge, again to the right, the multicolored gauge on the regulator is reminding us of the pressure that's left in the cylinder. That's an important factor for controlling and managing the oxygen to the patient over time. So the question now for everyone that's watching is, what is the flow? What do we see here? What is the flow? And the answer to the question is, the setting is shown at 5 liters per minute. So this patient is receiving 5 liters per minute. The amount of flow will be appropriate according to the prescription of the attending physician. May give the order 3 liters per minute or 5 liters per minute, depending on the condition of the patient and the proper therapy. So now the really important question for you, the end user, and if you're not the end user, for those end users who are working for you as leaders in the hospital, how much oxygen is left in the cylinder? This is important because we don't want to run out of oxygen in the cylinder. And I make this a point to be addressed because I have come into the hospital ward to see the patient and how they're doing, and found that while the clinician was away, the oxygen was depleted. And even though the flow meter had been set at 5 liters, now there is no liters being flowed to the patient because the oxygen is depleted and the cylinder is empty. So back to the question, how much oxygen is left in the cylinder? Well, there's two ways to answer this question. One way is to answer in pressure. How much oxygen is left in pressure of gas? And the second way to answer the question is in volume of the gas. Remember, the volume of the gas and the pressure of the gas are two different criteria of measurement. The pressure is the easiest. How do you know the pressure? You simply read the gauge, the pressure gauge. Read the pressure gauge, in this case, PG. The volume will need a calculation that requires understanding and knowing the liquid liter capacity of the cylinder. I'm going to move through this pretty quick. Later, I can send the formula if you are interested, but this is the formula. The volume equals the pressure gas divided by 14.7. That's atmospheric pressure times the liquid volume. For example, we see on this pressure gauge, the pressure is 700. So in this case, we would divide 700 by 14.7, that's atmospheric pressure, and then multiply by the liquid volume of the cylinder. That will tell us how many liters of gaseous oxygen are left in the cylinder. For the pressure, we read the gauge. Just summarizing again, 700 PSI is in the cylinder. But now wait, we want to do something careful. We want to stop and replace the cylinder, not when it's empty, but at 300. Therefore, the existing pressure of 700 minus 300, which is the point where you want to change the cylinder, means you really have 400 PSI remaining of working pressure, that is pressure to work with. For the working volume, we would use a slightly adjusted formula, having subtracted that 300 PSI, meaning that the volume of oxygen that you have left to use is 400, not 700, divided by 14.7, multiplied by 48. That volume will tell you you have 1,306 liters of gaseous oxygen left in the cylinder. Okay, that's great. The formula is a little sticky, and again, this is something that you can think about, look at later. I'll send the formula or you can copy it from this slide. But why is this important? Well, it's important because how much oxygen you have left gives you the idea of how much time before you need to change the cylinder.
I think.
So the question is, at this rate of flow, at 5 liters per minute, how much time in hours is left before we need to change the cylinder? So we understand that 5 liters per minute equals 300 liters per hour. That's 5 liters per minute times 60 minutes is 300 liters in an hour. So the answer then can be calculated by dividing the total volume you have left in the cylinder, 1,306 liters, by 300 liters per hour, means you have 4 hours, 0.35, which is 4 hours and 17 minutes. That's how long you have. So as you're making your rounds, visiting your patient, you see your patient, you look at this gauge, you say, okay, I know this patient's taking 5 liters a minute. I need to be ready to change this cylinder in 4 hours. That'll give you time to prepare the cylinder, order the cylinder, have the hospitalist come to confirm the cylinder should be changed, the patient flow should be the same, but you can be prepared to change that cylinder and continue to serve the patient. Let's look at a different cylinder. How much oxygen is left in this cylinder? The answer, 300 PSI is remaining. And the rate of flow is 3 liters per minute. But now is the time to change this cylinder. This cylinder shouldn't be allowed to be used any longer. Let's bring it because you're about to run out of oxygen. This patient was a pediatric patient suffering from hypoxemia, was on a cannula, but was about to run out of oxygen very shortly. Change the cylinder. So let's shift from worrying about the cylinder gauge to managing the humidifier. The humidifier is essential to preventing the airway from becoming dried by breathing a dry oxygen gas. So the oxygen goes from the flow meter through the humidifier. And and it's basic and simple to take care of. It just needs to be cared for. Distilled water is preferred. I recognize that oftentimes distilled water is hard to come by. You could use boiled water. If you use distilled water, it can stay in there for several days, maybe up to a week. If you use tap water, you should change it. You should change it every day. If it's not distilled or filtered, you'll have microbes. They'll grow over time, and sadly, the water becomes worsened and contaminated, and it becomes unhealthy for the patient. So we want to care properly for the patient by caring for the humidifier. Here's the clean humidifier container on the left. And then you see in the center one that's slightly not so clean. And then you see the one on the right that's in use, and that's terrible. It's filthy. Sometimes you see not only this kind of contamination, but actually algae or mold growing in the humidifier because it hasn't been washed or kept clean, and that is actually being entrained into the airway of the patient. So let's please avoid that. We're getting to the end here. Let's talk about some final safety mandates. Use no oil. Maintain the oxygen purity. You can see that this is repeated on this flow meter regulator 3 times because it's so important. Use no oil, and then a little image, an icon of an oil can. Use no oil. Do not lubricate these with oil if they seem sticky, or you're trying to remove them from the cylinder and you think you should lubricate it. Do not use any oil ever. And then some final safety mandate is the reminder that oxygen is a hazardous material. It can never be used around open flames or smoking. It can greatly increase the risk of fire if it's exposed to open flames. So there should be no open flame devices or smoking to be allowed anywhere near a place where oxygen is being used. I'd like to say this concludes my part of the presentation on device management and these critical devices for providing a patient care through oxygen therapy. I want to congratulate you all and thank you, because you are the ones that are saving lives. So thank you very much. Monica, back to you. This will conclude my part of the presentation.
Thank you, Jim. I know I'm just paying attention to the time. We are 20 minutes over schedule. We will, if folks need to leave, please go ahead. But I think we will take another 10 minutes, if that's okay with the panelists, to just go through any questions that have come in, either in the chat or from the pre-registration. Anna, are you, I can't see you in my video, but are you still on? We might have lost Anna for a minute.
I know her screen blacked out, so she was going to log back in. So I know she was trying to get it back. Yeah.
Okay.
I see her back on. I think she cannot unmute herself.
Oh,
yeah.
there she
Chase, are you able to unmute Anna?
Hello.
There we go.
Welcome.
Yeah, thanks. Yeah, we have some really, really great questions. And we also have additional resources to share with the group. One of the questions I think a lot of people have is, what processes are involved in supply chain management? How do you manage essential drugs and equipment in low resource countries? Understanding key suppliers of critical oxygen therapy devices. Another question about minimum caps per orders, per shipment, stockpiling, et cetera. And I think a lot of these questions have a similar answer, in that it really depends on your own institution. Each institution or facility has its own methods of identifying suppliers of medications and equipment, and also has its own people that are in charge of taking care of equipment, ordering equipment, it's finding the best price, etc. I know we do have a large audience from Africa, and the African Union has just instituted a great resource of African-made products, and it's called the African Medical Supply Platform. And I did post a link to it in the chat box a bit earlier, I think, or maybe I just sent it to Papicho. But that is also listed on the Learning Resource Center, so I can show that. Monica, would it be okay if I answer some of these questions by showing references in the Learning Resource Center?
Yeah, absolutely.
Okay, so I'm going to go ahead and share my screen.
And there are still some questions coming in through the chat, if you can see those.
Okay. So I'm going to share my desktop, so apologies for my email. I think many of you have seen the Learning Resource Center online, and the Oxygen series is one of the courses on this Learning Resource Center. And within the Oxygen series course, there's access to all the previous sessions we've had, including the recorded webinars. So if you miss a session and you want to come back and watch it later, they're listed there, as well as on the Assist International webpage. If we come down to session 5, that's where the supply chain management and oxygen safety resources are listed. We have one video uploaded that includes most of the information that Jim spoke about. But we also have links to key resources, including guidance for oxygen therapy devices from the WHO and UNICEF. Technical specifications for oxygen concentrators are also listed here, so you can actually go through this manual from the WHO that has a lot of key information about oxygen concentrators. If you click to the next resource, this is a oxygen supply and demand calculator that can be found online, and you can essentially type in the type of oxygen source you have at your facility, whether it's a plant, a cylinder, or liquid oxygen, and then estimate how much oxygen your facility is using. And using this calculator, it can help you make decisions about if you're ordering oxygen supply, what type of supply would make the most sense for you. So you can compare your needs to your supplier's options and see if it's most cost effective. There's another resource called the Medical Oxygen, COVID-19 and Oxygen Selecting Supply Options, and this was a nice article that was recently released, and it goes through the different types of oxygen supply, so you can read through this and decide what makes the most sense for your facility and your patient population. So that's another great resource. There's another slide share deck about oxygen gas cylinder safety. As Jim mentioned, fire hazard is one big concern around storing and handling compressed gas cylinders safely, but also they do have a risk of explosion if not handled correctly, and can cause lots of damage and be lethal. Another question was about essential medications and essential devices. The World Health Organization has many resources online for this. It also has needs assessments, and also can help providers link to resources for suppliers. So you can do these surge calculators, you can do forecasting tools, workforce requirements, and then emergency global supply chain catalog. So you can access that catalog here as well. So that resource is listed. And then they also have an essential needs assessment that is also for emergency equipment and emergency medications. Let's see, what else? I think this is the article again. This next link is the African Medical Supplies Platform. This takes a second to load. But you can actually see the different categories of supplies from Africa. And so you can click through this catalog to see if these products would be relevant to your needs. So I'll stop sharing there, but again, all of this is on the Learning Resource Center platform, and it answers a lot of the questions that came in. A lot of people are asking us to share or send you emails with the links for the videos and the resources. And I think the easier way to address your needs is to have you visit the Assist International resource page and the Learning Resource Center, where a lot of these materials are hosted. So those links we can provide again. You can do that now in the chat box. And I think instead of emailing individuals, individuals would be easier to do that. We had another question about appropriate oxygen rates for patients, and we have addressed that in previous sessions. The appropriate oxygen level delivery depends on the patient's needs and also the oxygen delivery device that you're using. So we have different maximal levels of flow for a nasal cannula versus an oxygen mask, etc. The other consideration is around wasting oxygen. We realize this is a precious and expensive resource. So you want to use the device that's most appropriate in that regard as well. A lot of facilities have developed what are called equipment committees. So if you have a group of individuals or at least one or two individuals at your facility, those you might want to put them on task to determine the needs of your facility and then have them investigate the best suppliers and resources.
Great, thanks, Anna. Well, we are a half an hour over, so I know there are additional questions in the chat, but I think we should close out here. We will have access to all these questions. We will try to address some of them in the follow-up email that we do send out, as well as include additional resources, as Anna mentioned, on our 2 sites. If Alana, you could just share the final. So I just want to again thank you to all the panelists for going through that presentation. I do think it was really helpful for everyone and really insightful and a different perspective than what we've been sharing over the past few weeks. We do have a WhatsApp group that you can join. The QR code is here, or if you have any issues, please email us if you're having issues joining. That will help continue the conversation. Most of our panelists are joining the WhatsApp group, and so if you have additional questions, please reach out through that platform. I do want to take a chance just to thank our funders who make all of this possible and support us: GE Foundation, Grand Challenges Canada, UBS Optimus Foundation, and the Alma Philanthropies. And we do have another session next week, same time, same place, focused on monitoring and evaluation in regards to oxygen therapy. So again, please be in touch through WhatsApp, through email, through our Learning Resource Center, through the Assist International COVID response page, and we will send out a follow-up email with all of these recordings in each of the languages, the presentation materials, as well as, again, any other links or resources that we can find that may be helpful for everyone here. So thank you again. And Chase, I'm not sure if we have a poll today.